Alright, so next up we have aortic aneurysms. And there are two main types of aortic aneurysms. A thoracic aneurysm, as you can see here, as well as an abdominal aortic aneurysm, which you can see here. Now each of these have different associations, and we'll discuss these here. We'll start off here with the abdominal aortic aneurysm. Now abdominal aortic aneurysms are going to show up on all levels of the USMLE as well as COMLEX. And thankfully, in clinical practice, most are asymptomatic, and we're either following their growth or screening for them in patients with multiple risk factors. And now while you're unlikely to receive a question about an asymptomatic abdominal aortic aneurysm, you do need to be able to identify patients that come in with symptoms, as well as identify the underlying disease and the associated risk factors. So let's start off with some associated risk factors, and you can see a table of these here. Now these are essentially the same things that you see in coronary artery disease or any other vascular disease. And the typical presentation may be an older male smoker with long-standing hypertension and known coronary artery disease. A few other examples that you can see here are diabetes, age, as well as family history. Now all this is important, so make sure to commit it to memory. So what do you think an abdominal aortic aneurysm presents like? There you go, it's going to be with abdominal or back pain. And if they have abdominal pain, it's most likely going to be radiating to the back. And why do you think the pain radiates to the back? Well, the abdominal aorta is a retroperitoneal structure, which leads to referred pain to the back. Now, if you need to review retroperitoneal structures, you can do this from the GI section, and there's a great mnemonic for it: SAD pucker. Now, if you think about it, what's another common disease that would present with similar pain? There you go, it'd be pancreatitis. Pancreatitis also often presents with abdominal pain that radiates to the back. So how are you going to differentiate between the abdominal aortic aneurysm and pancreatitis on your test? Well, one's going to be in a 42-year-old male who's an alcoholic, or a 46-year-old female who's overweight. And what do you think we're talking about here? There you go, pancreatitis. And the other is going to be a 67-year-old male smoker with hypertension, hyperlipidemia, and diabetes. And who do you think this is? There you go, that's going to be your abdominal aortic aneurysm. Now, knowing common presentations for your common diseases will serve you well on test day, as well as on the wards. Now, the pain here with an abdominal aortic aneurysm is due to the stretched aortic vessels pushing on the surrounding structures and nerves. Or, in the case of rupture, it's due to blood directly irritating the nerves. Now, in rupture, the classic vignette is an elderly male smoker presenting with severe abdominal pain, hypotension, and a pulsatile abdominal mass. Or they might even show you a CT scan like this one. And what do you see here? Well, you see an enlarged calcified abdominal aortic wall, as well as this large crescent-shaped structure, which is a thrombus within the vessel due to a large abdominal aortic aneurysm. Now, something else to note is that the abdominal aorta below the level of the renal arteries is particularly susceptible to atherosclerosis. Now, this is because below that level, the abdominal aorta has no vasa vasorum within the adventitial layer of the artery. This means that oxygen and nutrients must travel through the lumen, through the intima, then the media, and finally to the adventitia by diffusion. This increases the risk for injury due to decreased circulation over time and increases the risk for plaque formation. Then the plaques within the vessels will further block diffusion, leading to increased injury. Now, one more completely random fact about abdominal aortas. Dogs really don't get them, and this is because they do have vasa vasorum within their aorta below the renal arteries, which is something humans don't have. Now next up, we have the thoracic aorta, and the thoracic aorta contains and distributes all the blood delivered by the left ventricle. Due to this, it must be able to withstand high pressures and high wall stress. And if the aorta cannot handle these, an aneurysm will begin to develop. So with that said, what do you think are a few associations for thoracic aortic aneurysms? There you go, long-standing poorly controlled hypertension, connective tissue diseases, as well as a bicuspid aortic valve. Now, with a bicuspid aortic valve, the pressure exerted on the aorta is increased, and over time this leads to dilation. And this is essentially the same process in hypertension, but it's the hypertension itself that leads to the increased pressure and dilation of the aorta. Now, one important point to know here is with a bicuspid aortic valve, it's due to the aortic valve itself and can be seen in the absence of hypertension. But if you have hypertension as well as a bicuspid aortic valve, this can further accelerate the disease. Now, some common connective tissue disease associations include Marfan as well as Ehlers-Danlos syndrome. And now, can you remember the genetic defect seen in Marfan syndrome? There you go, it's a mutation in the FBN1 gene, and this leads to defective fibrillin production. If you need to review this a little more, you can find a great description of Marfan syndrome in the biochemistry section. Now, another classic association for thoracic aortic aneurysms is tertiary syphilis. Now, while this might be rare these days, it's still more than fair game for your test. And the spirochetes here, treponema pallidum, can end up in the vasa vasorum of the thoracic aorta. Note here that the thoracic aorta has vasa vasorum, while the abdominal aorta below the renal arteries does not. And if the spirochetes here block off the vasa vasorum within the thoracic aorta, what do you think you'd see? There you go, you'd develop an aortic aneurysm. Now here you can see an electron micrograph of a biopsy taken from the vasa vasorum. The spirochetes here are actively residing within the vessel. Then our immune system starts to attack the spirochetes, and this severely damages the vasa vasorum, hence the name obliterative endarteritis. Now all of this significantly deprives the thoracic aorta from receiving adequate oxygen and nutrients. And the end result here is a weak vessel wall that is susceptible to dilation. Alright, now just a few more thoracic aorta associations to cover. This next one occurs if you're driving a car 100 miles an hour and you run it smooth into a tree. What do you think is going to happen? Well, that rapid deceleration injury will actually rip the thoracic aorta from the aortic isthmus. And this will result in exactly what you think it would, a traumatic aortic rupture. Now, how do you think you would treat this patient? Well, here's the kicker. You wouldn't. They would just die. If you unintentionally rupture your thoracic aorta, you're going to bleed out, and there's not much that anybody can do about it. Now, what about if you dilate the thoracic aorta? What do you think would happen there? Well, if you dilate the thoracic aorta, you're going to end up dilating the aortic outflow tract, as well as the aortic valve annulus. So what do you think happens to the aortic valve? Well, it begins to spread apart, and you develop an aortic regurgitation murmur. So if you get a question about a murmur and someone with a known thoracic aortic aneurysm, be looking for one of two murmurs. Either the systolic murmur of aortic stenosis due to a bicuspid aortic valve, or the diastolic murmur of aortic regurg due to a dilated annulus. Alright, well that's going to wrap up aortic aneurysms. See you in the next video.